So I just want to introduce my co-moderator for this session and ask Dr. Schamberger and Dr. Habib to make their way to the podium. Dr. Croccoli is a pediatric surgeon and medical director at Bambino Gesù Children's Hospital in Italy, one of the only research hospitals in the central and southern regions of Italy. So welcome and thanks for being here. I wanted to introduce Dr. Simone Habib. She is a pediatric surgeon from Sao Paulo. She graduated from the Pontificia University in Sao Paulo and completed her general surgery and pediatric surgery at Escola Paulista de Medicine in Sao Paulo, where she also earned a master's degree. She's currently professor of surgery at the Paulista School of Medicine and head of pediatric surgery and surgical oncology at the Federal University in Sao Paulo, Brazil. She's a past IPSO president and past president of Safe Kids Brazil, and currently is the director at large for the Global Initiative of Children's Surgery. Welcome. And then I wanted to introduce Dr. Bob Schamberger. Originally from Missouri, he has spent all of his training and essentially his entire career in Boston. He was chair of the Department of Surgery at Boston Children's from 2003 to 2011. He has been a founder and essentially inseparable from the Wilms Tumor Study Group, POG and COG clinical trials, where his efforts have been enormous. Too many to summarize here. He's been past president of APSA, IPSO, a recipient of the LAD medal. And so this last session is going to be very informal. There are no slides to look at. We really just wanted an opportunity for especially some of the younger trainees and younger surgeons in the group to be able to ask questions about their phenomenal careers. So I'll open the floor to questions. Want to go first?
So thank you for allowing me to be part of this nice meeting. I'd like to move on a different path now because we are all tired. And so we have to raise our attention. So I want to ask to our colleagues what they do in their daily practice. What is their daily routine as a surgical oncologist? Because everyone knows what we have to do. We have to deal with our oncologists that ask us to schedule the surgery when they want, in the space they want, in the schedule they want. So it's like, something like a fight. I think that, yes, everywhere is the same, everywhere we have the same problem. So what is your, daily routine?
Well, first, thank you for the opportunity. I'm so honored to be here. Thank you for the question, Alessandro. I would like to say that first, multidisciplinary approach is what brought us to have the results that we have today. So, although we surgeons are very proud of what we do, it's a teamwork. And I think that bearing in mind that, and that everybody wants the patient good, we have to have the wisdom to navigate with some things. Every time you go to a meeting, whichever meeting it is, of course, each part knows what each one wants, right? So the oncologist wants the schedule that day, we have the availability that day, and the child is such and such, and everything that can come together for the child to be there. So, but we have to be wise enough to give some space for building together, because the child needs the expertise of all of us. And if we just are stuck and say, this is the whole truth because I want it, and all of us are human and we have that, who is most needing all of us, will be punished somehow by our pride, by our prepotence. And this is nothing to do with surgery technical skills. This is human relationships. So, and this is something to be built, and it takes time, and it takes patience, and it takes positioning yourself, putting some limits, of course. There's nothing worse for a surgeon than do a procedure which you are not very convinced that you should, but the multidisciplinary team says you should, and then it begins bleeding, and the multidisciplinary is not there. It's you alone, right? Or with your team to that. So, of course, we have to position ourselves not to make the final word, because otherwise we do the same as we are complaining to our colleagues, but to protect the children from what we know that surgery can cause as benefit or as damage. So I think that the secret, if there is a secret, is to build confidence among all the multidisciplinary team. And this takes time, commitment, as in any other relationship. Yep. Did I answer? Not very well. Not a surgical answer.
So, so I would first like to say, in full disclosure, there are multiple senior surgeons here who could be answering these questions. So Dr. Beebe and I are honored that we were selected to be placed between you all and the reception. But we were silly enough to accept the invitation, so here we are. So I think, though, this is a challenge that obviously occurs at all of our institutions. And I think to best deal with this, I would have several recommendations to the younger pediatric surgeons here. The first is that it's implicit upon us that we need to know the language that the oncologist and radiotherapist are using. And that means that we need to be conversant with the protocols that our patients are being treated on, whether they are those of PSYOP or COG, and in the past, other NWTS, G, and CCG and POG. I became first involved with the cooperative trials on NWTSG, led initially by Giulio D'Angio and then Dan Green. And I must say that they were two leaders who very much bought into and preached the cooperative nature of the multidisciplinary approach and clearly acknowledged the roles of surgeons and radiotherapists and pathologists much more than some of our current leaders may not accept. But they were the role model to which I think we need to aspire. So the first is to know the language, be involved in the programs, and for all of you, I would encourage you to participate in the cooperative group trials in your country and institution so that you are then seen as team players and hopefully equals in the decision-making process. The second thing is to obviously try and attend all of the tumor boards that are held that are going to be discussing your future patients. And I know the oncologists are not necessarily always good about scheduling these in the time of the day when surgeons can attend, but somehow you have to warp your schedules into where you can participate with them. How to adjudicate challenging problems. I think that as surgeons, we need to have use our training and perspective to bring to light the issues that what was termed earlier, I think it was by Dr. Davidoff, the courage of the non-combatants. In other words, I think they need to appreciate the challenges that our patients may face with the recommendations that they are pushing us to perform. And I think it's our responsibility not only to try to comply with the mandates of the protocols, but the bottom line has to be what's most important for any individual patient, even if it means not, participating with 100% of the guidelines. And I think as long as that's our perspective, that most of the time our recommendations will win the day. One of my mentors, Dr. Judah Folkman, always said that if we take the perspective of what's most best for our patients, that invariably we should win the discussion.
Mm-hmm. Yeah, of course. May I add something, because I think that you are asking very detailed, how do you do? So I think that we should bear in mind some things when a child needs surgery for oncology. So you have to know about the disease, what is known about the prognosis of the disease. You have to know what is the situation of the status of the child. Is she or he well enough to go through that? What is the last date for chemo and radiotherapy? This is very important for surgery, especially if you are not only in elective procedures, but also especially in the emergencies that might come to you. And then the surgeon should balance what kind of quality of life can I do? Is it possible to do a curative procedure or a palliative procedure, at least in the meantime, if it's an urgent procedure? We have to deal with wishes and expectations of the patients, of the parents, of the multidisciplinary teams, and with our own. And we have to, I think that's the worst, our own expectations. So what I have been learning is, and I thank every day for the patients and their families for teaching me that. We have to be very clear about what is our role. At first, in my, I would say, being naive, or maybe you would want to be the savior. And when it goes well, wow, it's good. But if it doesn't, is it your fault? Really? Do you have that control of everything, right? You have the control of what is in your hands. Do you do your best? So, and the other thing is the child, and this we should learn from them to do too, is although they are very severely ill, they are children, and they live the moment and they play. So we should be like that too, and accept that we have limitations, and accept that we cannot fix everything. And even though we don't have what to do, our presence is important. So we have to learn to deal with our sense of impotence. Yeah? Accepting things as they are, especially for palliative care and difficult situations. Just one bit. We always say the phases of loss, right? Denial, anger, bargain, whatever, until acceptance. We always refer this for the patients and their families, but we go through the same, right? So we have to accept where we are, or do we accept the situation before I go and give some bad news? So this is important too.
And this session is completely open for anybody to ask questions, so we certainly don't want to monopolize. But while you're coming up with questions, can you each describe or recall maybe one of the most influential memories, experiences, people that really had an impact on your career and that you have used moving forward as you educate the next generation of surgical oncologists?
This is heavy.
Sorry?
This is heavy.
This is heavy. You can breathe. I will too. So I could say I have a list of stories to tell. I was just, well, when I was invited to this, but I'll stick to the patient, the first oncology patient that I had. I had contact with him as a general surgeon resident. And he had a Burkitt's lymphoma with an ileostomy. And I was introduced to pediatric oncology surgery by Professor Schettini, who is now retired. And I owe him most of my surgical teachings and learning and everything. I have many people to thank, but I'll stick to the patient first, otherwise I'll get lost. And this boy was my patient for 3 years. So after I ended general surgery, he was still there treating the lymphoma while I was a pediatric surgical resident. And in the end, he relapsed and had a pleural effusion. And then the intensivist or pediatrician, I don't remember well, was going to do relief thoracocentesis for symptoms. And then he said, "What do you think you are doing? You are not a surgeon. Please call Dr. Simon." So I think that this is so rewarding because even though it was something that might cause discomfort, of course we all care for pain and whatever, but the confidence that was built was so impactful for me. So I wanted to share this with you. This was very impactful. And many of my teachers, of course, have national and internationally speaking, contributed to my formation. And as we speak to young surgeons, be a very good general surgeon, be a very good and interest in all the cavities surgery, and be good at critical maneuvers for trauma, transplant, or whatever. Because although the protocols tell us what to do, until we accomplish that, many things can happen and you should be ready, right? So always do your best and train. There's always something to learn, yeah? And that's a great blessing, always something to learn.
So I came to oncology before I actually came to pediatric surgery. I worked in a surgical immunology research lab as a medical student, and then through my first couple of years of general surgery training was planning on being a surgical oncologist. So I arranged to go to the NCI in the surgical branch after my third year of residency. But during that year, I had a 4-month exposure to pediatric surgery and a 3 months exposure to kids at the Shrine Burns Institute. So I decided I wanted to do pediatric surgery at that point. So I was committed to go to the NCI since it was a governmental contract and I didn't want the feds coming after me. So I worked there, and at that time, both Steve Rosenberg and Murray Brennan were two of the PIs. And I would say that they really, during my time there, I learned about how you actually carry out prospective oncologic trials and how you perform research in the laboratory that I think probably was the exposure that most affected my subsequent pediatric oncologic surgical career going forward.
We can hear you. Yeah.
Okay, I have a practice-related question, and that is, so in my group, I'm sort of recognized as the pediatric oncology leader of the group. How do you, and we're in a relatively small group, 4 surgeons, how do you, from a practice standpoint, I'll tell you why I'm asking this. I get a lot of calls from the oncologists about little details, big details. More and more of the workup are done outpatient, and sometimes my partners want to also be, they want to contribute to the care of the patients. They want to do some of the operations. We often operate together. So how do you distribute cases between a practice in oncology? How do you bring up the next generation? What do you do for succession? How do you kind of distribute all that among a group to make the surgeons feel like they're happy and participating? Should they not? Should you have oncology be totally separate? That's my question.
So obviously I was forced to, shall I say, deal with those issues when I was the chair of a department where we tried to let surgeons basically do the cases that they had referred to them and that came in when they were on call at night and so forth, and sort of preached against policy at some other institutions where it was very segmented from the start. What I saw that transpired over time, though, was that the oncologists always have a desire to keep, how would I phrase this, the oncology cases in a limited number of hands with whom they feel very comfortable. So I had to fight against this a little bit. The one thing that we had developed as a policy in the department, though, was that for really complex oncologic cases, bilateral Wilms tumor, high-grade neuroblastomas, and hepatic resections, went to a designated small cadre of surgeons. By the end of my tenure, we were up to 23 surgeons, and if you divide the oncologic resections among 23 surgeons, we'd be doing a couple a year, so to speak. So that wasn't optimal. But what I found transpired was that because my colleagues knew that I was heavily involved in oncology for the more standard cases that would come through the emergency ward or from referrals from the pediatricians, they would always come and just ask about, what's the best way to do this biopsy? Do you think we ought to do this resection before chemotherapy and such? And, I was quite comfortable dealing with it in that manner. And I think the oncologists were generally okay with that if they knew that the care plan had my imprimatur for how it was going to be approached. But I do think, and Mark's presentation today, I think, was a testimony to the fact that I think for the more complex oncologic cases, having them done by a limited number of individuals clearly has benefits to the patients. And I think that has to be the bottom line that we work by, is always what's the safest thing for the patients. If colleagues had tumors that came in that fit into those complex categories, the three of us that were sort of assigned, if you will, to the complex oncology would assist them, or they would assist us in doing the procedures if they wanted to participate. I found that in most cases, they were just as happy letting us deal with the really tough cases as trying to do them themselves.
I would agree to that. So I might tell some stories about that. So in my university, when I was a resident, there was only 2 beds for oncology in the pediatric ward. And when the children came for surgery, they came to our ward, which is on the same floor. And that was it. And Professor Schettini, although being a surgeon, was the one that administrated chemotherapy for the children, and operated too, because there was no pediatric oncologists in the institution. I was not born there, but then Dr. Petrilli came, and he began to build the NGO. First, it was a small house for outpatient chemotherapy. Then it became one building, 11-floor building, where we have an operating room, we have ICU, everything devoted to pediatric oncology. So answering your question, we did not have that problem within the pediatric surgery team because the others did not want anything to do with oncology. Sometimes we get some of them to help us in something, but nothing very frequent. And then we were in another building. So we were acting both sides, and we became a team devoted to pediatric oncology. And now there's a second building, and so we have, I think it's more or less 40 beds just for pediatric oncology, 20 ICU beds in the institute. There is a genetics lab, there is a biobank. And so I was learning this, all the surgeries in parallel with this story, you see? And what we were the first institute like this in Brazil, and we graduated specialties from all the subspecialties dealing with children with cancer throughout the country that are building other centers that are specialized. It's not centralized because only in my city we are 21 million people. Mark has been there. And so imagine the whole country, and we also receive patients from Latin America. And with this structure, we were able to hire our results similar to those in the high-income countries, which was not possible for any Brazilian child before that. And then for the succession question that you asked, so after myself, we formed 2 surgeons that are now respectively working elsewhere in other cancer centers. And the younger, I think that it takes a very long time to do what we do. And although we are in the reference centers, for you to be experienced in something, even today we have doubts. So we always learn. And I think that we have to get the younger generation in. So we train, we are the official rotation for pediatric surgical oncology of many other institutions and universities. We have a fellowship program. And in Brazil, we now have an alliance of 25 institutions devoted to pediatric cancer that have diverse complexity. So sometimes the most complex cases come to us, but the surgeons come along so that they can also see what happens and we can also teach. Yeah. And some of our faculty now is former fellows and former residents, which is very good. So, yeah.
Thank you, Dr. Rabib and Dr. Schamberger, so much for this. And I encourage everybody to ask more questions of them at the reception. So I just want to say thank you for a wonderful IPSO day to all the presenters. I think there's been some phenomenal work here that we have all seen, and it's just been a great day. So thank you to everybody. I especially want to thank the IPSO members who have traveled quite a distance, who have been really integral in planning and participation, and we really value your insight and collaboration. And then specifically, just to mention Dr. Losty, Dr. Winnan, Dr. Davidoff, and Dr. Louts, and a few others who aren't here, who were really helpful in putting this program together. So everybody should thank them for a wonderful program. The reception will be at 6:30 at the Tavern Terrace, which is at the Meritage Restaurant. I am told, I haven't been there myself, but if you go back that way, up the escalator, and then to the left, it's on the main level of the hotel. It's a little bit of a walk. So that's at 6:30. You do have to have your drink ticket to get in. If you're wondering if you can still attend, just stop by the registration desk and ask, because I don't know the answer. But thank you, everybody, and we'll see you at 6:30 at the reception.